health. Our first one last month was on our aging rural population. Today we'll be talking about mental health, and come July we'll be examining public health systems. This QR code will allow you to register for our future webinars. For today's webinars, we have three incredible panelists who will be talking about mental health issues from their unique perspectives, thinking about them from state government, from Western Illinois around the services of youth and children, and in deep Southern Illinois, thinking about family engagement. And so I want to take an opportunity to introduce those three panelists today. First is Dr. Debbie Reed. She is the president and CEO of Chaddock, a family of organizations focused on serving children and families struggling with attachment and trauma. Dr. Reed has served as the chair of the National Board of the United Methodist Association and the national CEO of the Council of the Alliance for Strong Families and Communities, the board of the Illinois Great Rivers Alliance, as well as the board of Quincy Area Chamber of Commerce. Dr. Reed is also the co-editor of the book Attachment Theory in Action, co-author of the book Raising the Challenging Child, and writes a weekly leadership blog. Administrator Kelly Cunningham currently serves as the Medicaid Administrator for the Illinois Department of Healthcare and Family Services. She formerly held the position of Deputy Administrator for Long-Term Care and Behavioral Health within the Division of Medical Programs of the Department of Healthcare and Family Services. She also oversaw operations for the Bureau of Behavioral Health, which is responsible for the development and implementation of children and adult behavioral health services under the Medicaid program. Prior to serving as Deputy Administrator, Ms. Cunningham served as Chief of the Bureau of Long-Term Care. And our third panelist is Dr. Matt Buckman. Dr. Buckman is a licensed clinical psychologist and executive director of the Stress and Trauma Treatment Center. Dr. Buckman is the principal investigator of the Southern Illinois Resiliency Project and co-principal investigator of the Illinois HEALS, Helping Everyone Access Linked Systems demonstration site project, an early childhood system of care project under Egyptian Health Department. Throughout his roles, Dr. Buckman provides supervision, consultation, and training, as well as direct services to children's, teens, youth, adults, and families to improve a variety of emotional and behavioral health issues. So these panelists are here after a convening of these partner organizations, talking to nearly 80 leaders from 55 organizations based on 11 discussion forums in the fields of 9 unique and different topics. Those leaders were from disciplines such as public health, healthcare, academia, industry, government, trying to think through how the pandemic was leading to new and unique challenges, but also how it was creating and providing and fostering innovation in our communities. The discussion forum participants were also invited to an additional session where they identified common challenges across those 9 topics and synthesized impactful solutions. Those conversations led to and are leading to a series of reports that first came through in March 2021, where this group of partners published a report called Building a Healthier Rural Illinois, Understanding and Addressing the Challenges of COVID-19. Since March and ongoing for the next 9 months, each topic, individual topic of those discussion forums will be featured with an additional report and accompanying webinar. And so this month's report, COVID-19 and Rural Mental Health, Recommendations to Improve Health in Illinois, was featured as our May 2021 report and will be the basis of our webinar moving forward. And so we will stop sharing that PowerPoint and we will get started. So my first question to you, Dr. Buckman. And as you think through your efforts in deep Southern Illinois, can you tell us a little bit about what the mental health landscape looks like in deep Southern Illinois? Some of the challenges and innovations that you guys face before the pandemic, and how that pandemic has changed the way that rural mental health is thought about in deep Southern Illinois.
Yeah, thank you for that question. So I live in El Dorado, Illinois, so pretty deep Southern Illinois. And oftentimes what we're finding is that even pre-pandemic, right, we have a shortage of providers. We have a shortage of licensed providers, and constantly working to try to build a pipeline to get more individuals in the profession, and also looking at some of our paraprofessionals, some of our individuals with lived experience. These are all initiatives that we were looking at a scarcity of resources and barriers such as transportation, and barriers such as just geography, or even barriers around individuals living in one community but having to go to a different community. Even if I can go there, sometimes from community to community, we can have differences in culture, belief systems, and access that is more than just physical access. But since the pandemic, we're seeing more and more places that we have to restrict services. We have to minimize the number of individuals that can get services. We have seen places that have unfortunately had to even close their doors. And in doing so, what we're finding is that access to services has been very limited during the pandemic. We are seeing some of this grow. One of the avenues that I see as one of the innovations, and one that I think a lot of rural communities are doing, is how do we co-locate? How do we collaborate together? How do we bring the services to where the families are, where the youth are? This can be schools, this can be healthcare clinics, primary care practices. How do we go to them and show that we're willing to be the ones that take the burden off of the family, that we go and we provide supports wherever we can, whenever they want those supports.
Thanks. And knowing that those challenges exist, throughout the state and throughout our rural communities, moving from Southern Illinois to kind of Western Illinois, and Dr. Reed, we know that children have had especially a lot of difficulties during the pandemic, school being altered, their ability to kind of socialize. How has that affected your part of the state, and thinking through the role that the Chaddock family of organizations has around children's well-being? Dr. Reed, you're on mute.
Sorry about that. Certainly, we saw very similar challenges to Southern Illinois in terms of just a dearth of services and not the level of support that we needed for our families. Transportation is always an issue. One of the things that we really encountered with the pandemic is we serve kids and families in a lot of areas where there is very little internet access or not reliable internet access. And so some of the ways that, for telehealth, ways to try to get some outreach only works if people have access to good broadband service. And that's not the case throughout the state. So that certainly was challenging. And for us, when kids weren't in school, when we weren't seeing kids face to face, we weren't putting eyes on kids, where if perhaps their parents were having mental health issues, some of those folks that are kind of that first line of defense to identify when there are challenges that a child is facing weren't putting eyes on the kids. And so that was certainly a concern for us. And very early on, we worked, collaborated with our schools, with other social service providers, recreational providers, a whole group of folks to survey our parents and kids as the pandemic was setting in. What are your concerns? How can we be helpful? So we actually heard back from more than 2,200 parents and children on what some of their concerns were. and how we could be supportive. And, obviously coming from the parents, childcare was a concern, food, the emotional and special needs of their kids, and internet access were the top 4 concerns. And so we really looked at how can we reach out. We had a special Facebook group that kids and families could tap into. We've tried to provide support to the parents, and we've tried to provide training and support to other community providers, whether that be schools, social service agencies, that the children and their families might be in contact with, to give them the skills to be able to provide a supportive response wherever the kids and families might interact with other care providers. And so I think really looking at how can we extend our reach by equipping others to provide supportive services, and to directly ask kids and families what would be most helpful to you. So often we experts think we know what families really need, but to really reach out and ask the kids, ask the families. Not having county fairs might not seem like that big of an idea or big of a challenge to some people, but for a child that's where they had a lot of socialization. There were some real that created some concerns, and kids' use of the internet went up. I saw a survey that said during the pandemic, kids averaged more than 5 hours a day on social media. And we know that there are mental health implications from that. And so really tried to look at how can we find new ways to connect with kids and families, even with some of the challenges of transportation, of internet service, and how can we make sure the mental health providers we have can reach as many kids and families as possible.
Yeah, no, thanks for that, right? Both the challenges and the innovations. And so, Administrator Cunningham, we know right from the data that 83% of Illinois counties are mental health shortage areas. That's nearly 5 million people. 85% of them live in rural Illinois. We know that 90% of psychologists and psychiatrists, 80% of social workers live and practice exclusively in metropolitan areas. We know that 81 of our 102 counties don't have a child or adolescent psychiatrist. And so not only was that the issue sort of before the pandemic, and now the pandemic creates a whole bunch of other challenges in the way that we think about healthcare and behavioral health delivery. And this is you as the Medicaid administrator. So how did you guys approach or even think through approaching such a big problem that was magnified, and ways that the state of Illinois adapted to this new care environment?
Sure. Thank you, Dr. Vora. So I'll start. I think what I want to do before I, try to answer this question or dive into it is certainly thank all of the community behavioral health centers, local mental health providers, other, panelists for the work that they did during this pandemic on the ground. From the Medicaid perspective, I feel like I had the luxury of being able to go to an office and to sit and try to interpret policy, passed down to us from the federal government and from our legislature, and try to mold a program to meet people's needs without actually being in the position of doing that like you all are every day. And so just a thank you and a shout out to you all for the hard work that you did and are still doing during this pandemic. I think the first thing I want to highlight is the importance of telehealth and what telehealth brought to the Medicaid program during the course of the pandemic. I have the ability to talk to other Medicaid directors around the country, and by and large, state Medicaid agencies are not we're not real risky. We tend to be a little conservative in our approaches, and I think everyone agrees that if there is anything as such as a silver lining during the pandemic, it's been the ability to really pivot to delivering some services through telehealth. There are certainly challenges with telehealth, broadband capacity, having the appropriate equipment to utilize that. But I think that was a really important pivot that, happened virtually across the country in terms of Medicaid programs. We were able to switch many of our community behavioral health center services and our children's behavioral health services to a tele-based platform. We decided early on we were going to pay the same rates as a face-to-face service, and that we needed to also make sure that we covered individual group settings, and tried to preserve access as much as possible during a time when we knew that people would be crying for access and possibly even needing greater access than they did before. That would be the first thing I would highlight. I think the second thing, Dr. Vora, I'd share is that we try to work with our behavioral health trade associations, some of our provider groups, advisory groups. We looked at some of the definitions of mental health case management services under Medicaid and made some temporary, but possibly things we'll consider permanently, additions to what constitutes a case management service, expanding to things such as, purchasing and delivery of food, prescriptions, telephones, that type of thing. So we really decided early on that we had to sort of take off, we had to step out and take a little risk in this area. And, I think we were hopefully well positioned to help our providers preserve access as best they can in an environment where people are not able to travel and meet with their therapist face-to-face. So really probably stressing technology, tweaks that we can do in definitions of services. We also, I know, tried to focus some of the federal money we were able to get appropriated to us through the General Assembly. There was some Federal CARES Act money. HFS had the ability to help to direct, and so trying to get money out to provider communities, long-term care providers, hospitals, the whole Medicaid array of providers to help keep their businesses operational.
Yeah, thank you for those efforts and the need for both flexibility, but understanding how this translated back to the individual and the community. And thinking about that, Dr. Reed, much of the work in Shattuck, right, sort of extends through the school that's part of the family of organizations, the different services that are provided. And what we think about so acutely in terms of mental, behavioral, and developmental services, the need for trust, and sometimes the issues of stigma that still move through in discussions around mental health.
Mm-hmm.
Can you speak to that a little bit on how the way that the Shattuck family of organizations talks about sometimes mental health issues, and
Mm-hmm.
that knowing that more people are struggling because of the pandemic, how we can elevate the importance, but also make it feel as normal as possible?
I think relationships are absolutely critical. And so that's part of what helped us really navigate through this. And I think looking at where are those relationships? Maybe it's someone in the school. Maybe it is, someone that they come into contact through a social service organization. And so really having a way to kind of scaffold together those individuals that are supportive and in contact with the child and family. And I think, what we really try to make sure is, too often historically we've seen, a child has to get bad enough and the challenges have to get bad enough to be able to really kind of provide the supports that they need. And so we're working very hard with a whole network of individuals who come into contact with our kids and families. How can we help them gain the capacity to know, if I have a traumatized child here, this is the best way for me to respond, not to trigger their behaviors to escalate more. And so we're really looking at the overall health and well-being of the child, and not trying to wait until that child gets to the point of having a clinical diagnosis for a mental health challenge, but really to provide the supports around them. That takes partnership. And historically, so many service providers, so many funders, different state agencies were very siloed in how they did their work. And yet they were addressing consistent issues across the different departments and across the agencies. And so I think it's really incumbent on all of us to look at how do we work collectively so that we can provide the most supportive network and community for our kids and families, so that we're just looking at their overall well-being, not waiting until they have a diagnosable mental health issue.
And so to that point, Dr. Buckman, we do, right? We struggle at times because it is often about mental health treatment, and we know that there are gaps there. But often our push across, no matter what provider you are around health, is that you want to prevent that crisis moment from happening. And much of this is a link in systems. And part of the goal, often around mental health, is this idea of a system of care. And with your role in Southern Illinois, both with the HEALS project and the Early Childhood Systems of Care project, how have you worked on, and with your partners, thinking about what that means, not just as a theory?
Yeah, it's a good question. And so this idea of systems of care, of, this is, and it's a new term, but it's really like community, right? And like, this is the life that all of us live, and healthy individuals usually are living in healthy communities and healthy systems that and there's not one place, and oftentimes we might fight over certain territory type of issues, but whenever it comes down to it, we all care about the same things. And how do we all collaborate and maybe pool resources, maybe think about where there might be some redundancies in some of the work, because there's plenty of work out there. But when I get down to it, I'm thinking about, like, who are the major sectors, systems that families, individuals are relying on or needing, and how do these systems work together or work against each other sometimes? Some of the very concrete types of strategies is sometimes I'm just a translator, that I can go from one side to the other and be like, when this sector, when this group is saying this, they really mean this. And it's the same thing you're saying. We're really doing the same work. Let's just work together in that. And when you talk about, Dr. Reed, about the importance of relationships happen at many different levels throughout our systems of care. And many of our individuals that we're trying to serve, their relationship with the system is the system has hurt them in many ways. And so how do we repair that relationship and our relationship with each other? That sometimes as sectors, we might throw the other sector under the bus to try to compensate for what I might have messed up on, or maybe I could have been more responsible for. And then the last thing I'll say is, it's sometimes, and we can call it collective impact, we can call it system of care, we can call it different things, but really it's about us community members, us citizens, taking responsibility for everybody else, for all of us, that we work together to make better communities, healthy communities. And that can prevent a lot of what we end up having to address in our treatment.
Yeah, so well put. And tossing it back to you, Administrator Cunningham, part of it, right, is that in order to speak the same language for a child and family, you have to have access to the same information. And I think even as a primary care pediatrician, it's, well, okay, I'm hearing this about what's going on at the school, but what's going on in my clinic, and maybe I only have 20 minutes to see a patient. But part of that, and I think sometimes we use the academic term, it's about data. But really, it's about a shared understanding.
Mm-hmm.
So how do we, and I know this is a real concentrated effort by the Department of Healthcare and Family Services, how do we work on that shared information, even knowing that the Department of Healthcare and Family Services is a different department than public health, and it's different than the State Board of Education? What are strategies or ways that thinking from community all the way up to the level of state government that we can begin figuring out how that information can be shared?
That's a tough question, but such an important issue. And I really want to echo, what Dr. Buckman and Dr. Reed said about the importance of relationships and trust. I know one thing that we have been striving to work with at the department, and this isn't new, but I think it became really crystallized during the pandemic, was the relationship we had with our sister agencies, including, the Department of Human Services, the Department of Children and Family Services, the State Board of Education, and the Department of Public Health, just to throw out some examples, to make sure that our focus is on the individual. Really, we're trying to focus on the individual, the customer. We've done a lot of visioning and strategic planning work at the department, actually right during the pandemic. It started about the first week of February last year, and we carried it through. But to really focus on our customers and establish that as an expectation for our staff, for how we deal with customers, how we deal with providers, and with our state agency partners. I think the other thing I would highlight too, and this may get more specific to data, but the department has had an effort ongoing for several years now, and I won't say that it's been widely acclaimed. I think there have been a myriad of reactions to it, but it's the adoption of the IMCANs, that assessment instrument for use with children behavioral health needs, determining the level of behavioral health needs, but also built into that assessment is the ability to capture so much more information about that child's situation, about the family situation, in order to, not so much to standardize the information, but more to give us a picture into that particular child's situation, and to help communicate better, with providers and across providers. So, I guess I'd point to maybe two things, the sort of internal reset I think that we've all had to do to address fragmentation, and just, trust issues, and really realize that if we don't we have to do this together. I mean, we were, thrust into a major public health crisis, and if we wanted to keep government operating and for our customers, our clients to have access to services, we had to do it together. And then probably just more the specific emphasis on utilization of a more common data set, mm-hmm. and, establishing an expectation, and, how that data was going to be used, how it was going to be collected, and really kind of putting in that at the basis of our system work in children's behavioral health.
Mm-hmm.
Yeah, no, thank you for that, Administrator Cunningham. And part of where we wanted to kind of segue and the things that we have been discussing up to this point, right? We're talking about relationships, we're talking about trust, we're talking about shared understanding, and knowing that how debilitating a mental health challenge, crisis, but even the beginnings of that can be both for our ability to do the things that we love to do, but also for our physical health. And in our conversations rose three ideas that we'd love for the panel to kind of think through. What do these make sense? Are there certain things in our current systems that prevent this from happening? And how could we think about even some of the innovations that you've talked about going on in your communities and in state government, that these things are already happening to some degree? And so those three were: one, think about a statewide telepsychiatry program to connect rural Illinoisans, because we know that there are such gaps in coverage, to timely and effective mental and behavioral healthcare services. Two, how do we think about better integration of mental, behavioral, and substance abuse treatment into our primary care systems, knowing that it's not just mental health providers that there are shortages of in our rural communities, but all providers? And how can we get to a spot where it is a little bit of a one-stop shop? And if you might have had some hesitation to think about that with mental health, if it's all part of your general wellness, how could we incorporate those things? And then how do we invest in piloting and scaling new models of mental health services? I think there are options here, especially for our children and aging, but we can think about them all across all age groups that customize care based on individual needs and integrate with social service sectors. And to Administrator Cunningham's point, that these are our clients, and how do we meet the needs of individuals and their families, knowing that it is a little different no matter what family you're in or what community that you're in. And so as we take the screen, maybe just to open it up to the group, initial reactions to that, and how some of your work, knowing the innovations that are happening across the state and then in your individual communities, that these things are already happening.
Mm-hmm. I would say certainly in terms of the telepsychiatry and the telehealth that's happening, probably the biggest barrier to that was the providers feeling like we could do that. The children and families are very accustomed to looking at screens to get their information. And I think that, together with the broadband challenges that some of our rural communities have, is one of the key barriers to that. I think absolutely we have to integrate behavioral health and physical health and find creative ways to do that. I know we were part of a collaborative effort where we actually have for lack of a better term, a bus that goes around to rural communities that is set up to be able to offer physical health, behavioral health, and dental health for those with transportation issues. But those collaborations take time. And so I think for us to make sure, that was a couple-year process to get to the point we had that. And so I think that we know what the challenges are. To me, that was a big takeaway, is there wasn't a lot that came up in the pandemic that we didn't know this was a challenge, but the pandemic pushed us, whether it's funding, opening up more flexibility, that now we hope stays, to have that added flexibility, or, we knew where the challenges were. I think that allowed us to respond more quickly. My hope is that we continue to move forward in really tackling and working collaboratively to address those challenges, because I think we know what they are. And we really have to say, how do we become most accessible for the kids and families? Not what's easiest for us as providers, but how do we work together to really meet our kids and families where they are so that they can tap into the services that are available?
I'll add just a little bit. I love everything you said, Dr. Reed. And as we I like how we're thinking like from a rural perspective and rural mental health for children and families, that some of these same experiences have been there, some of the same challenges have been there. And now COVID-19 has really exacerbated that, has really increased the importance of we need to tackle this. But as it became an everyone type of challenge, that affected people differently depending on where they are and what type of situation they might be in, the context of their life, what we ended up finding was options became more available, right? So then that increased access. And when we get into telemental health and telepsychiatry, whatever we were looking at is like, I'm not sure I'll always want to be able to do this. I'm not sure if I want to. We all had to do it. We all had to find a way. And it turns out it's still an option. It's a possibility. That, oftentimes we use that expression of like, it's about who you know. And what we find is that the haves have bigger networks and they have more connection to people. And the have-nots, they don't have these connections, right? Many of us, our first job is through somebody else we knew, somebody our parents knew. And so unfortunately, those with smaller networks have less access, less opportunities. Two things that I think of in that. One is when we add mental health, that's over or virtual, telemental health, telepsychiatric services, telehealth services. What we're doing is now, it's not just about who you know. It used to be in rural health, it's about where you live. And there's differences between rural health, right? There's differences between the size of a city I live in that's 500 versus the size of a city I live in that's 9,000. 9,000 may seem really small, but it's kind of big in some of our areas in Southern Illinois and other parts of Illinois. And so it was about where you lived and then what kind of options did you even have? But now when we get to virtual, we're opening this up. We're giving people options. It doesn't mean they have to take it, but we're giving people options that now, do you even have to go to a brick and mortar anymore, right? Is that an important aspect of it? Do you have to travel an hour, which is some treatments, some services, that's going to be the case, but we don't have to. And we give these options to folks. And do you have to settle for the one psychiatric, the one psychologist, the one mental health provider that goes to your school or your city? Maybe there's options now. And I love that we have these options that are available. And the last thing I'll say is we talk about individuals as Director Cunningham, as you talked about individuals and how we're looking out for them as consumers, clients. I think about the network and what would happen if it's my child. Like, what links would I go to connect her with what she needs? Who would I call? What steps would I skip just to be able to make it happen for my child? And I think that's the way we need to start thinking about all of our kids, is how do I use what I have and not save the favor for when my child needs it? I might have 4 or 5 kids back here that they need that extra slot in that after school program. They need to be able to be seen on that one Saturday appointment that happens once a month. I'm going to use my favors, my connections, my networks for the people who really need it. Because honestly, it's probably not my child. It's probably other people's kids that have had less advantage, less equity in this world.
I'm so glad you brought that up, Dr. Buckman, particularly what you just said about equity. One thing we've been focused on, or really seriously focused on at the department over the last several months, has been the rollout of a healthcare transformation collaborative initiative, which sounds like a mouthful, and it kind of is a mouthful, but in short, what it is, it's the product of many months of work that we had undertaken with the University of Illinois at Chicago, and stewarded by the Medicaid Working Group in the Illinois General Assembly and a lot of stakeholders and other providers to really create a program with some money attached. That's always good when there's like new money attached, $150 million or so in the first year, to really incent communities to come together and propose ideas around healthcare transformation to the department that contain, and these collaboratives can be groups of, traditional, non-traditional Medicaid providers. They could be a hospital system and a community behavioral health center. They could be a community behavioral center and a federally qualified health center. I mean, there's all sorts of possible combinations here. This was a program approved by the Illinois legislature back at the mid-January of this year, and we're in the process of getting the first round of applications scored, evaluated, and funded by the end of the year. And the whole goal of this is to incent healthcare transformation, but to do it through the eyes of the community itself. I mean, one of the things we've struggled with is, what is healthcare transformation? You see a proposal and you're like, is that transformative, or is that just the way it should be done? Or, sometimes it's hard to know it when you see it. And, from the perspective of really relying on that community, the group of individuals and entities that they have pulled together, what they have done in terms of stakeholder and community input is absolutely essential to the application. And we are also looking at incorporation of, while traditional healthcare services are fine, but really a focus on those social determinants of health, which I don't think we talked about a lot yet on this particular panel, but I think really underlies both what you were saying, Dr. Buckman and Dr. Reed, is getting children and families what they need. We may have known this for some time, as agency leaders and policymakers, but the pandemic took so much of the veil off, and access to food, jobs, transportation, getting to school, all those types of things really took on a sharper edge during the pandemic. So one of the things we're focused on is this formation of sustainable collaboratives that can come together, address specific needs of a community in the way that they define best. And we're really looking at trying to plant some seeds there to grow some non-traditional partnerships and some more effective, and I think you were saying, Dr. Buckman, almost more effective and efficient ways of doing things. You too, Dr. Reed. Let's not wait till we're at a crisis. Mm-hmm. Some of these issues, if we can figure out better, more effective, more evidence-based ways to address issues before they're a crisis, I mean, it's incumbent upon us to do that.
Absolutely.
All wonderful responses, and more information. We had sort of referenced those healthcare transformation collaboratives in our report, and I know you can find them at the HFS website as well. One to sort of sometime now on our audience questions. We're getting a number of really good ones. We'll try to kind of get through a couple and get all of your responses. So we know that the pandemic has made us, from a statewide and a local level, enhance support services. And agencies, local communities have enhanced support services, but sometimes the public just doesn't know about those services. And so on a statewide and local level, how have we tried to use different communication platforms? Dr. Reed, you mentioned sort of a Facebook group as one of them, to talk about some of these enhanced social services that are really thinking about mental and behavioral health.
Mm-hmm. Yeah, I think, again, looking at, and as agencies, whether it's private organizations or state agencies, we are not always at the front end of the curve of whether it's using text to let people know, remind people about appointments, to get information to people where they are at. And I think that, ask our people, how do you best want to receive the information? I think sometimes that's where, we experts may not have the lived experience that those we're trying to serve have. And so how do we honor and ask for how can we best get this information to you? our families that we're serving will tell us if only we ask. And so I think that's one of the things that perhaps we could get a little better at, is to truly partner with our families. It's not about us imposing our great wisdom on them, but how do we partner with them to make sure that we can work together to best get their needs met.
I would agree with that, Dr. Reed. One thing, it makes me laugh a little bit, but we just in the last few months have discovered at Healthcare and Family Services, and we're a large state agency, that we have a Facebook account. But our Facebook account wasn't active and actually hadn't been updated in a number of years. Because I took a look at it and I'm like, oh, that's back in 2016, you know? So, I mean, just simple things like using social media, Facebook and maybe other mechanisms to do that, just to publicize some of the work that we're doing and to provide, you know, get resources into people's hands about eligibility, about, you know, applying for benefits, you know, linkages to services and resources. I mean, you know, you're absolutely right. Our clients, our customers are very accustomed to dealing with information on screens and through phones, and it doesn't always require us to prepare 90,000 letters and have them sent out in advance, you know, only to get 20,000 of them back with bad addresses. But, you know, we really do have to become much more nimble and flexible in terms of, you know, meeting our customers' needs for information. And, you know, social media, text, you know, let's take advantage of this technology, you know, that's available to us and that we have seemingly been so reluctant to embrace.
Yeah, I agree with that too. And I think, yeah, social media, text, and the technology can be, it's a tool, right? It can be a great tool to be able to add to the belt. If someone doesn't trust me already, they're not going to trust me if I send them something over social media either.
Right.
But, you know, where we can develop that and cultivate that trust that we need with our consumers, the individuals in our communities that could benefit. Some of the innovation, I just think about schools. I love partnering with schools. I think schools and healthcare align together. Oftentimes we're working on the same things. Many times we can integrate, collaborate. But many times I'm sending stuff back in home in backpacks where we're sending that out, or in lunch programs. We're rural schools just across the nation. Have been open more than some of our more urban partners, right? So a lot of our schools are in. Many times my friends and colleagues that were living in Chicago, that they would talk about not being able to go to school, whereas we maybe didn't even shut down. Like the school my daughter goes to, we went the entire year. We never stopped going in this school year. And so there are different opportunities. So sending things back in backpacks, we became kind of a pickup and drop off location for different resources. And so it really does make a difference when I'm promoting something and I've got something in hand. Right. Sometimes I might be bringing it to people's doors that might need that, or sometimes they're going to be coming through and be picking up food boxes and things, and then I can share some resources. We've even incorporated our law enforcement partners and trying to help them get a more outreach aspect or be seen more than just what people might think of them, and that they are really public servants. And so we've been partnering in that as well. Our churches, getting out, having pastors provide announcements and things like that, that makes a difference. We had a community event at a park, and so that way we could keep it COVID friendly and we could be spread. It was a scavenger hunt about mentoring specifically was the goal of that, using our El Dorado Children's Cabinet, a specific city children's cabinet with the superintendent and mayor as the chair for that, but being able to give lots of platform for connection and identification of resources. And this connection of like a person still matters, even 6 feet away, I can still build a relationship. But I need to know that person. I need to know who it is, even if it's a 30-second conversation. That's powerful for our consumers, our families, to get to meet people and realize that button's just as flawed as everybody else, right? We're all just human beings trying to be human beings and try to help each other along the way.
Mhm.
Yeah, no, great. And maybe one more question and try to, so maybe some specifics here as we know we're getting short on time a little bit. But another great question, what resources short of getting a degree in clinical psychology like Dr. Buckman, are there for citizens to learn how to adequately respond and support individuals with mental health issues? You know, our questionnaire here volunteers with an agency that provides assistance to low-income individuals and wants to figure out how to serve them more effectively. How would you guys advise that?
You know, I think one of the, if you call it a benefit from the pandemic, or one of the things that has really resulted is lots of organizations are putting information out that people can tap into. I know we put together a pandemic parenting guide that it's not just for parents, but adults interacting with kids. There are lots of resources, more and more information on being trauma informed and how to interact with a child. You know, some of our programs use parent coaches that, you know, these aren't people with advanced degrees. These are people with very practical skills. How do you take the theory that we can all read about and learn about? What does that mean in this moment when your child is doing this? How should you interact? And I think there's more information out there than certainly in the recent past. And I think that's come because of the pandemic, that people are really have been very generous with sharing information and tips and tricks that I think caring adults can have the greatest impact on a child's life. And as providers, I think a lot of us have worked really hard at getting more tools in the hands of those caring adults so that they can intervene in ways that are most supportive. And, you know, if they're, you know, we work with a lot of behavioral challenges, really de-escalate and help the child feel that sense of safety that they can share what's going on with them.
Yeah, and maybe as we kind of think through a final question, and would love this from all three of you. So what comes next? What is one innovative idea or policy that you hope could be implemented to build brighter mental health futures for all of our residents across the state of Illinois? And Administrator Cunningham, I'd love to start with you.
Sure, I can think of a couple of ideas, and just going off of what Dr. Reed had just shared. One thing that I have noticed, I mean, almost consistently on a daily basis are, you know, either campaigns or hotlines or little snippets of information on television or a variety of other places, really seeking to end the stigma or address issues of stigma around, you know, around mental illness, and the importance of really trying to acquire mental health services if you think you need it, if you think your friends need it or your family needs it. And that's something I'm just so grateful to see, and I see it daily, and I certainly hope that continues, because it's long overdue and badly needed. We can't step back from that. You know, so I think that is really important. I also know that many states, including ours, are really looking at how best to continue telehealth services, the provision of telehealth services through Medicaid. You know, the federal government really they play a relatively small role in this, but it's an important role in this, because the federal government, the Office of Civil Rights within the U.S. Department of Health and Human Services, sort of governs some of the HIPAA protections, the privacy protections around telehealth communication. And so we are, you know, actively watching for further guidance from the federal government, you know, as we continue in the public health emergency. But watching for further guidance, you know, from this arm of government to determine what they are going to find acceptable and appropriate for states to continue to allow in terms of HIPAA, you know, HIPAA protected communication. So that's something I think that I'd like to see, you know, continue as appropriate
No, wonderful. And as we are kind of 2 minutes before the top of the hour, I just want to thank all three of you for such an incredible conversation. I know I learned a great deal, and I know our participants did as well. We know all of you are busy doing incredible work in your communities and across the state of Illinois, and to be able to share your expertise around rural mental health issues is greatly appreciated. So we're going to kind of shift in our last 2 minutes to let you know that these conversations will continue to come. One of the things that we're taking a break next month to bring forward the Southern Illinois Health Care and Southern Illinois University Health Policy Institute. We will have an incredible day of sessions from the former Deputy Secretary for Health and Human Services, Eric Hargan, to a agency director panel where Director Eagleson from HFS will join Secretary Ho and Director Callahan and Director Basta, and then really think about the parallels and differences between rural and urban disparities and how we can think about unique solutions in each of those spaces statewide. We will then be back with the third part of this Rural Health Summit webinar series on July 15th, where we are going to speak to public health systems. And so we'd love for you to join us then, again, during the lunch hour at 12 to 1, where we'll talk about COVID-19 and public health systems. So thank you, guests. Thank you for our participants for joining. And we look forward to seeing you hopefully at the Health Policy Institute and with our third webinar on July 15th. So take care, everybody.